Good evening, everyone. Welcome to the UPMC public webinar on urology. My name is Trina, General Manager, UPMC Ottawa Hospital, and I will be your host for this event. This event is a public information session designed to educate and inform on common male and female urological conditions, including symptoms, diagnosis, and treatment options. There are two talks this evening presented by my esteemed consultant colleagues, Mr. Kashif Siddiqui and Mr. Nabeel Al Shammary. To ask a question, simply type your question in the Ask a Question tab below. Please do so early on in the session to get your questions in. We will then have a live Q&A session after every presentation. Our first presentation is from Mr. Kashif Siddiqui. The title of that presentation is Female Urinary Incontinence and Male Benign Prostate Hyperplasia. And we will go over to the first talk now. Thank you.
Good evening, everyone, for joining us on this webinar tonight. I've been asked to talk about urinary incontinence and benign prostatic hyperplasia. Both of these topics are very much prevalent in the general population and quite extensive, making it very difficult for me to put the whole thing together within 10 minutes. But I will try my best to make it as simple as possible and to make you understand what the condition is and what are their management options. We start with urinary incontinence, which is defined as involuntary loss of urine. There are three main types of this: stress urinary incontinence, urge urinary incontinence, or in other terms, overactive bladder, and then a mix of both, which is the mixed urinary incontinence. I should also refer to overflow incontinence here, which happens because of weak detrusor muscle in the bladder, which we will talk about further in the next slide. Stress incontinence, as the name says, it is leakage of urine due to increased abdominal pressures. And this can happen because of the coughing, laughing, lifting, even walking, dancing, and other activities. Obesity, postmenopause, pregnancies certainly can affect this aspect as well. Whereas the urge incontinence is slightly different. It happens because of overactivity in the bladder, where the bladder nerves become hyperactive and they don't give you enough chance to make it to the bathroom and lead to urgency, which in turn in severe cases can cause urge urinary incontinence. It's important to recognize them separately because the most common variety would be the mixed incontinence, and it is important that we know which is the most bothersome component of the symptom, which will dictate the further management options and the sequence of management. The symptoms that we are more interested in is going in detail of what causes the leakage. And many times, as I said, it could be mixed, but many times women would be able to tell us that which is the more bothersome component. Those who are going for long walks, interested in sporting activities, complain of leakage with exertion, with coughing, with running, and that is very evident that is more than likely because of the weak pelvic floor muscles, which can be secondary to, like I previously mentioned, previous pregnancies, menopause, overweight, and hormonal imbalances as well. The urgency could be idiopathic, which means that the nerves are just overactive for no reason, or there could be inciting factors. There could be other stimulating factors, which we try and identify in the history. One thing that I mentioned before about the overflow, which happens mostly in men, and with bladder outflow obstruction, which is the second part of my presentation, related to benign prostatic hyperplasia, when that is ongoing for prolonged periods, can lead to weak bladder, which in turn behaves like a balloon, starts storing large quantities of urine, and in turn overflows when a person goes to sleep or when the person is very relaxed. Then there are some functional aspects to incontinence as well. Cognitive compromise, mobility could be factors in that. In all of this, it is very important to identify the red flag factors. For example, visible blood in the urine. For example, if somebody is having recurrent infections, particularly men who may have stones in the bladder because of bladder outflow obstruction, or there might be neurological signs, someone presenting with multiple sclerosis or other neurological Parkinsonism, for example, may have neurological signs which in turn can lead to incontinence because of that. Pelvic prolapse or pelvic mass leading to again obstruction of the flow, which in turn leads to overflow. There could be significant blockage of voiding symptoms, which can also lead to incontinence. We try and make out about the frequency and the nocturia, which is how many times a person wakes up at night. Depending on the age, waking up once or twice would be very much normal. But if someone wakes up more often, then that needs to be addressed. That needs to be worked on and investigated. How many urgency episodes does a person get, or how many pads are used? And that gives you a rough indication on how the severity of the problem is. The goal is obviously to improve the quality of life. This is not cancer, this is not life-threatening, but it can significantly decrease the quality of life, and the incidence of urinary incontinence in all age groups amongst women is very high. Many people think that it's part of aging, but the incidence could reach up to 50-60% up to the age of 65, and certainly can go up to 70% even in women who are above the age of 65. So it's a common problem, but many times people accept it, women accept it as being part of aging. Like I said before, that the minimum that we do would be a history taking, assess the significance on the quality of life and what bother factors are there. Do a pelvic exam, which usually is not done in the clinic, but at the time of cystoscopy, if that is indicated, we can do a cough stress test, which is just simply filling up the bladder and getting them to cough to look at the severity and also to look at the prolapse if there is any. The urinalysis is to check for infection. You must have seen those dipsticks being done in the surgery where we check for the protein or the nitrates, which would be more consistent with infection. But it is important to send it for culture and sensitivity to identify the organism which is causing the infection and also the antibiotic that can work in those situations. The bladder diary is an important aspect because many times people don't realize how much fluids they are taking, how many times they are avoiding, whether they have caffeine drinks, whether they are taking sugary drinks or fizzy drinks, which would all be very much stimulant to the bladder. So just a simple exercise of maintaining a bladder diary for 2 to 3 days can give anyone an idea that how much fluid you're taking and how much is coming out. And a balance between that can help with the management. Certainly a condition which is called nocturnal polyuria, which just means that people pass more than half of the urine output of a 24-hour cycle during nighttime. And that has got a hormonal basis rather than any other functional basis. The PVR means post-void residual, and that is checked to check on the overflow incontinence, that the bladder is emptying fully after the void. Urodynamics is a very specialized investigation, and we don't do it as a first-line investigation, but it is crucial in identifying where there has been previous surgery, where there is unclear that whether it's stress or urge components which is more bothersome or which should be treated, or at the extremes of ages, certainly with problems in the elderly or in very young men and women. If there is mixed symptoms, then we do urodynamics to understand the bladder pressures and whether there is any obstruction to the urine flow. What we can learn from the urodynamics, like I said, to understand the pressures in the bladder, which is the detrusor overactivity, we can understand the urethral pressures and also the compliance of the bladder, because sometimes because of repeated infections, previous radiation, or other pelvic conditions, the bladder capacity can be compromised, which has no or little storage left in the bladder. And because of this smaller capacity, the frequency and urgency happens. Obstruction which happens mostly in men because of the prostate, or underactivity, like I mentioned, that the bladder muscle goes weak, can also lead to incontinence. The urodynamics would be most helpful when we are considering incontinence surgery, and particularly, as I said, when the symptoms are mixed. If it is a clear, straightforward stress incontinence, then I would not be reluctant to go ahead and treat it. But if the symptoms are mixed with urgency, then certainly to understand the bladder pressures will give us a better idea. In the management part, the first step is always lifestyle changes. People come across, and we do come across people who are taking a lot of caffeine. And certainly in Ireland, we have seen that a lot of women are very fond of their tea and taking tea in mugs and big teapots, keeping them on the side and sipping away all day or all evening can lead to these symptoms getting worse. So certainly lifestyle changes need to be addressed. The pelvic floor muscle training, which is pelvic physiotherapy, can be undertaken by a trained physiotherapist through a regime which goes on for nearly 6 months with regular planning, and that can help with the symptoms as well. And if that doesn't help, then there are different things that can be addressed in that. For example, in the medication part, in overactive bladder or the urgency, the first line of treatment would be a common drug that is being used called mirabegron or betmega, which stimulates one of the receptors in the bladder, increases the capacity, and reduces the urgency or the frequency. Also, there are other drugs, for example, the anticholinergics, they're called, which can lead to dry mouth and dry eyes, but they can also help with urinary frequency and urgency. Unfortunately, there is no drug that would help the stress incontinence. There were drugs checked, but there was only subjective benefit in that because the problem does not improve with drugs. There can be devices or pessaries used for stress incontinence, particularly for the pelvic floor muscle training. Sometimes it works, but in the severe forms of incontinence, it may not work. Then we come on to, after the medical or the conservative treatment, we come on to the procedures that can be done. And bulking agent, previously sling was the most important and most successful treatment that was being done. But since it was found that these slings can erode into different areas in the pelvis and can lead to pain, the slings have been abandoned. And now the minimally invasive treatment is bulking with a water-soluble drug called Bulkamid, creating a bleb around the urethral opening, leading to coaptation of the internal urethral orifice and in turn affecting the stress incontinence. It can be done within 10 minutes as a day case under general anesthetic and has nearly 65 to 70% success rate. As I said at the start, that the purpose is to improve the quality of life, and that is what we are trying to achieve here. Then coming on to the overactive bladder or urinary urgency, Botox injection would be the next line treatment if the tablets don't work. The Botox and the Bulkamid, they both may have to be repeated. Bulkamid can usually be given 3 times in lifetime. Botox can be repeated every 6 to 9 months, which would be the average life of about 9 months. But it can, and with repeated injections, it blocks the bladder nerves to help with the capacity and to help with the urgency and the frequency. Then there would be complex cases, refractory to other treatment, where there would be different specialist pathways and different other treatment options available for them. The Bulkamid dose is usually given up to 2 mils at one time, as I said, to create a coaptation and a bleb of the drug, which can be done under general anesthetic, which is very easy to do with very few complications, may have to be redone, and a very small risk of urinary retention. It may need a top-up or it may need a redo. The success rates, as I said, would be around the 70-75%. And this would best fit for mild to moderate stress incontinence. I've had a number of patients who are athletes, who are very active in the gym. They would go for long hike walks and so on, and they have had fantastic, tremendous result from this, and they're very happy with the outcome. Coming on to the other management options of the stress incontinence, obviously the mid-urethral slings, which were previously done, are not being done anymore, or more severe surgeries like Birch-Colpo suspension, where the bladder is lifted up, or like autologous fascial sling, in which a sling is made of your own fascia and treated by placing it under the urethra to help the symptoms. These would be for more complicated cases which do not respond to the first line injection treatment. Coming to the Botox, usually we normally start with 100 units, give in different parts of the bladder, and the efficacy would be certainly a high percentage in terms of success rates. The Botox would work nearly in 70 to 80% of women after the first injection, and we have the option of repeating it or even increasing the dose of that. Remember, Botox is for overactive bladder and urge incontinence rather than the stress incontinence. There are other ways. If the Botox doesn't work, then we can go for sacral neuromodulation. Augmentation cystoplasty is quite a major surgery, which was the mainstay treatment, say 20, 25 years ago, but is rarely being done these days. Or there could be intermittent self-catheterization that can be taken, or urinary diversion can be taken in as well. For mixed incontinence, obviously, as I said earlier, that the main point is to understand what is causing the most bother and treating that first. Any patient may need both treatments, but which one is to be done first, because the treatment can overlap with each other as well. So now coming on to the benign prostatic hyperplasia, or talking more about the male LUTS. LUTS is a term used for lower urinary tract symptoms, which is a combination of storage and voiding symptoms. The storage symptoms like waking up at night, frequency, urgency, or the voiding symptoms like weak flow, hesitancy, straining, or even post-micturition dribble or incomplete emptying could be there as well. So a combination, some people may have 1, 2, 3, or maybe more symptoms, or maybe all symptoms. So it's a combination of symptoms, and we need to identify that which aspect is more bothersome before we understand the treatment options. We do use quality of life questionnaires sometimes and do a baseline test, which means enlargement of the prostate checked out by prostate examination, doing a urine test, and also the PSA. I would like to emphasize here that enlargement of the prostate is just a natural phenomena that happens with aging and does not mean cancer. This is a common misunderstanding that many men would have, that enlarged prostate in turn means cancer. No, that is not true. And even the PSA value changes with age, and the PSA value is certainly specific for prostate, but it is not specific for any condition of the prostate. The PSA could be high because of many reasons. Prostate cancer is not the most common reason for the PSA to go up, and prostate cancer is not the only reason for the PSA to go up. So remember, high PSA does not necessarily mean cancer, and enlarged prostate does not necessarily mean cancer either. We do check the urine flow because that gives us an idea about the level of obstruction or the level of problem that they have. And then if need be, we could always do ultrasound or even a flexible cystoscopy to assess the bladder and the prostate to understand the management options. Over here also, we need to look out for the red flag signs, which means somebody might be in urinary retention, they may be getting urine infections, they may have blood in the urine, or even renal failure, and all these would be straight indication for surgical management, because the bladder outlet obstruction in these situations do not respond to medical treatment. In the medications, there are 3 ways that we can deal with benign enlargement. Firstly, to observe. In some people, if the symptoms are not bad and if the urine flow study is not that bad, then we could just observe them. Or alternatively, after that, we could start them on a group of tablets called alpha blockers, which relaxes the prostate, or we use the 5-alpha reductase inhibitors, which can reduce the size of prostate as well. There are combination drugs that can be used in different population also, and the PD-5 inhibitors, for example, the tadalafil, which is also used for erectile difficulties, can be used in lower dosage for benign prostatic hyperplasia. We sometimes have to add the antimuscarinic or the anticholinergics for storage symptoms if need be. Surgery is offered, like I said, if the symptoms progress on medication, if somebody presents with a complication of the condition, or if somebody prefers to go for surgery upfront, which in many cases is preferable. There are different types of procedures that are available these days, and going through the most common would be the transurethral resection of the prostate, which we do with a bipolar current these days. And the advantage is all of these procedures are done through the urethra, so there's no cutting or no stitches involved, but the bipolar resection has lesser risk of bleeding, has better outcome, and certainly there's no TUR syndrome, which used to happen before, where people would have problems in the post-operative period. So all of that has been taken care of. For very large glands, over 100 grams, the option of laser enucleation is there, or laser vaporization can be done in younger men, where there could be preservation of ejaculation, and the same happens with Resume, which is the water jet coagulation therapy, which we can do in younger men. But the downside of that is after Resume, we have to leave the catheter in for a prolonged period, whereas laser vaporization or PVP, we may just have to leave the catheter in overnight. After HoLEP or bipolar TURP, usually the catheter is in for 48 hours. The Uroleft procedure was done like putting in a staple to open the prostate, but is being abandoned now because the results aren't that great as compared to the other options that are available to us. So overall, various options are available for different group of people, for different types of condition, for different prostate sizes, for different medical treatment, and different preferences. So all of those are being done, and they are available depending on the symptomatology and depending on the condition that we are dealing with. Certainly, again, going into a little bit more detail, the HoLEP, as I said, that would be the laser enucleation would be something for larger prostates, very large prostates, 100, 150 grams. So obviously they would have a longer lasting solution, whereas with the bipolar TURP, that might be achieved with second resection if need be. Sometimes for the bipolar resection, we can just do the median lobe resection, and that gives a very good symptom relief. If ejaculation is very important, then Resume or the PVP green light laser would be something that would interest people. So just coming to an end, I hope that this was helpful. I've just put down some references available to answer any questions if you have. Thank you very much.
Welcome back, everyone, and I hope you enjoyed Mr. Siddiqui's talk. Unfortunately, this evening, Mr. Siddiqui is held up in surgery, so he's unable to join us for the moment. So we will move straight away to Mr. Nabeel Al Shammari's presentation, which is prostate cancer diagnosis. And we will go over to that now and take all the questions after Mr. Nabeel's talk. Thank you.
Welcome, everybody, and thank you very much for your time joining me in this quick information about prostate cancer diagnosis and treatment. And I will be as quick to save your time. Nabeel is my name. I'm a consultant urologist and robotic surgeon at the UPMC in Ott Even Hospital in Kilkenny. And today I will speak to you about the modern prostate cancer diagnostic pathway and the rapid assessment that we have in Ott Even. So why prostate cancer matters to us as patients and GP and specialists? Because the first, prostate cancer is most common cancer that male men, especially in white men in Ireland, 1 in 7 or 8 men will have prostate cancer in their time. And the early detection of prostate cancer significantly improves the survival and the outcome. And many of our patients that first present through their GPs with no symptoms as just part of their general check, which I totally understand. And unless you ask for it or you have symptom, nobody will do the PSA, and that's the guideline. I wanted to understand when we need to do the PSA and the importance of having referral to from your GP to the urologist when you need. So the PSA is a useful screening test, but and it is a diagnostic marker, but is not a test that we need, that it's approved for the screening. That's the problem. The reason is that the PSA can be up from so many other causes, like inflammation of the prostate, infection, enlargement of the prostate, even infection in the prostate or the urine. Cycling, having intimate time, intercourse, all these will, even the examination by your GP or urologist can put the PSA a little bit up. In my opinion, persistent elevated PSA requires further assessment, and that should be done by a urologist. Sudden rise in the PSA on more than one occasion in absence of urinary tract infection should be checked by a specialist. There are many factors that increase the PSA. I list a few of them. The most common one is benign prostatic enlargement. Every man will have his prostate enlarged after the age of 50, but that enlargement is a program, is according to a program, is programmed enlargement. So we know that the PSA will be increased at certain level, and that is based on the amount of enlargement of the prostate annually. So your prostate enlarged is 0.6, 0.7 gram per year, and that will in return will have higher PSA by 0.6 to 0.7 annually. In my opinion, an increased level persistent need to be assessed, at least with the examination, and proceed. Recent ejaculation can put this up, prostatitis, urinary tract infection, any intervention in the urinary tract, and age. When we grow older, the PSA will go up. That due to the prostate volume increase. Here are the levels for the PSA with the age of 50, less than 50, 50 to 60, 60 to 70, 70 to 80 and above. Less than 50, our PSA should be less than 2.5. 50 to 60, less than 3.5. 6 to 70, less than 4 plus 5. Less than, when we are 70 to 80, our PSA should be less than 6.5. In my opinion, even if my level is 1 and start to increase in 3 months to 1.5 to 2 on 2 occasions, even if I'm younger than 50 or younger than 60, with the PSA level less than normal, but it is climbing up, I should be checked. So changing level is also important, not only being below the normal values. Examination of the prostate is done from the back passage and is done by the GP or the specialist, and that will give us idea about the size of prostate and if there is any abnormality in the prostate. And it's not exclusion for the prostate cancer, but it helps in staging and proceed with the next. When you get referred from your GP to me in Kilkenny or to any other colleague or urologist, you will have a modern diagnostic pathway, which will be PSA high, examination of the prostate, or even the abnormal examination only. That will trigger the further evaluation. First will be assessment for multiparametric MRI, which is magnetic resonance imaging of the prostate, and that would be before the biopsy. The reason for the MRI is to clarify the size of the prostate, show us the surrounding of the, like lymph nodes, the other structures. If there is any clinically significant cancer within the prostate, that will be targeted with the biopsy. Then we do the biopsy. And most importantly, if we do the biopsy prior to the MRI, we'll be unable to proceed with the MRI only if 6 weeks left, then to allow the area to settle after the needles and the bleeding within the prostate. And that's a huge delay if we need to treat urgently. And that's why we are doing MRI prior to the biopsy, to get target and to see if there is anything else need to be done urgently. So the key role for the MRI is to detect clinically significant cancer, to help to avoid unnecessary biopsy. If it is completely normal, we just correlate with the family history of prostate cancer. We check the PSA and how it behaves over past 3 years or so. And also to allow us to look to the other structures and local staging of the disease if it is highly healed. And then when we do MRI, it will give us idea to divide. I always tell my patients with color your prostates from 1 to 5. The higher you go, the higher suspicion of cancer. So 1 and 2, that's grade 1 and 2 in the MRI, is different than the biopsy. And also we have the size of the lesion if it is seen. So the bigger the lesion, of course, the higher the grade. So from 1 to 5 in the MRI, 1 and 2, they are benign. 3 is a gray area. And the 4 and 5, they're suspicion of cancer. We need to biopsy. Today, prostate biopsy is done under local anesthetic, sedation, and local anesthetic, general anesthetics in combination with local. The patient can come and discharge the same day. It total may be in the hospital 2 to 4 hours. Once he passes urine, he will go home. And this how we do the prostate biopsy. As you can see in the photo, on the right-hand side, the ultrasound probe go through the anal canal towards the prostate, and the needles will go between the scrotum where the testicles are and the ultrasound probe. On the left-hand side, you'll see the sites of the needle which will go to the prostate, and which part of the prostate which we go blindly, guided by ultrasound to saturate. Nowadays we take 18 cores, not 12 cores. This the imaging when I do the ultrasound during the procedure. So on the left-hand side, you will see the prostate. It's inverted. So the left of the prostate will be on your right and other way around. This circle surrounded by white dots, this is the prostate itself. On the right-hand side, you see small dots with a red circle around the prostate, and those small dots are my needle, will go through those. While we have the MRI, and in my from my experience, I can fuse both images and decide where to go with the needle. This were how to do the biopsy at the real time. The case I did, let's say you see this is the prostate, and this is the needle that's shining, and then it will fire. I will check that is all through the prostate in both directions, and that's done. Now, when you have your PSA checked by your GP, you'll be sent to us. You'll have the modern pathway, which will followed by the MRI examination. Any suspicion in the MRI will go with the biopsy. That will not take you more than 2 to 4 weeks to have all this done. And with that pathway, there is a huge improvement in detection of clinically significant cancer. And once we have the biopsy, we will have the risk stratification, and we stratify the patients to low risk, intermediate risk, and high risk. The risk category is a main guide for me to decide, or for any urologist to decide what option you will go for. Whether low risk mostly will be for active surveillance. Intermediate risk, you will have surgery or radiotherapy, focal therapy, so many other options. And if it's high risk, maybe even multimodality, surgery and radiation, or any other, or radiation, chemo, or any other option. And the main question to ourselves, when we should see our GP. I think if we have a new symptom, like I get up at night, although the prostate cancer have no symptom, most of the patients are asymptomatic. Only in late stage they may have blood in the urine or difficulty in passing urine, pain in the bone. Like if you remember the famous cyclist in Chris Hoy, when we have that shoulder pain and he attended the for investigation, found to have metastatic prostate cancer. Even he was in I think he's 48 or so. Yes, it's asymptomatic, but it's worth if you have family history concerning the prostate cancer. You should have your PSA with your GP, or you have a new waterworks, a new symptom in you get up at night, frequency, urgency, may be associated together with the erectile dysfunction, with anything. Lose nothing if you do the PSA as part of your checkup. I have a fast track, rapid access referral pathway, and you can always ask to be referred to my service in UPMC or TV in Kilkenny. Thank you very much for your time.
Welcome back, everyone, and I hope you enjoyed Mr. Nabeel Al Shammary's presentation. And thank you for your questions. I'm going to go down through the questions, and the first question that has come to us is, can you give me some information on the steam method to reduce the size of the prostate? Who is suitable for this procedure and how effective is it? I'm going to hand over to Mr. Al Shammary to answer that question. Thank you.
Thank you, Trina. So Resume is a steam therapy. We call it Resume, and it's available in UPMC in all branches. We do it in OT in Kilkenny. It's a minimally invasive treatment for benign prostatic enlargement, and we use a water vapor to shrink the prostate tissue through a telescope and a needle injected into the bladder, and this used for moderate symptom for patients who want to avoid surgery. That's mean cutting. It's a surgery, but it's a different modality. So for people with moderate symptom, want to avoid surgery, and they're usually used for the younger generation who want to preserve their ejaculation, and symptoms will improve over weeks. So it might take up to 6 weeks to have the fruit of the surgery. Good, effective, lasting up to 5 years, and slightly less effective than the gold standard resection or shaving of the prostate, which usually up to in best centers we did in Scotland. It was around 68% of 68 of 100 patients, they get their symptoms improved.
Okay, thank you for that. Thank you. That was very informative, Mr. Al Shammary. So I'm going to move to question number 2. I have always had overactive bladder. Now I am now incontinent most of the time, afraid to go for long walks as I will wet myself, up 3 to 4 times a night, even though I don't drink after 7 p.m. I am 75 years old.
Okay, so this history is suggestive of overactive bladder with urge urinary incontinence, where the bladder overactivity leads to urgency, leak, and frequent nighttime urination. This significantly affecting any person's life, actually, and causing fear of going out and disturbing sleep, despite of even the fluid restriction and having all the conservative measures. Here, the assessment is very, very important to differentiate whether it's urge urinary incontinence or it's a stress urinary incontinence or it's mixed. Because we have both of them, but we start to treat which one have higher effect on the patient. With the management here include the gold standard conservative first, which is the bladder training, pelvic floor exercise, and then next would be medication. So any medication here should be tried for 6 weeks and then to stop, unless we have side effect, of course. So these three things we use first. So bladder training, pelvic floor exercises, and I can add the healthy fluid to the bladder. And UPMC, we give the patients all the leaflets for full information, and they get referral for pelvic floor exercises. And we see them back in 6 months to see if they have a better chance. And this patient, which I think you said 75, also we may start them on hormonal treatment, local hormonal treatment to the private areas, and that will in form of Vagifem, whether cream or tablet, they are both the same, but according to the patient preference. They also have impact on the improvement of the making the local tissue healthier around the urethra, and that also will make a better response to any type of treatment we will go ahead. And then sometimes, even if we don't have full response to these conservative measurement, and I will always tell my patients, it's just like a ladder, there's 10 steps. So if you do these, you will be on step 3 or 4, and then you have another treatment like a Botox injection or any other treatment which decided for you. Then you will start from level 4 rather than 0. So it's always having these things like pelvic floor exercise, bladder training, healthy fluid to bladder will help for next step. Thank you.
Thank you, Mr. Al Shammary. Next question, question 3. What would you recommend for a sensitive bladder? And there's female in brackets on this question.
Okay, yeah. It's almost the same as the top one, but for the sensitive bladder or overactive, mainstay treatment, even if you go for any type of treatment, because there always risk of 10% failure in even the best treatment. So I would recommend bladder training and avoid irritants like caffeine, alcohol, fizzy drinks, pelvic floor exercises, medication if needed to improve to have better control. Yeah, thank you.
Okay, thank you very much. Thank you very much. And moving on to question 4, do you ask about menstrual history, e.g. menarche age, amenorrhea and menorrhagia? My pronunciations mightn't be great. Do you find these have an influence on urinary incontinence? Do you think a greater access to pelvic health physio would be beneficial?
Well, that's very, very good question. Yes, certainly. Not only me, any urologist you meet will ask about menstrual history. Hormonal factor can influence the pelvic floor function and urinary symptoms, exactly as I mentioned a moment ago. For elderly patients who are, or any female in menopause, they will have healthier tissues around the urethra and so forth when you have the local vaginal hormonal treatment. While not always direct cause of the hormone on the urinary function, of course, like heavy period, hormonal changes, menopause will contribute to incontinence, will contribute to overactivity, and a greater access to the pelvic floor physiotherapy will highly beneficial to any of those patients, in both for bladder overactivity, which lead to incontinence, or the frequency and urgency only. Actually, in my opinion, play the key role in the improvement. Even if you have any, let's say, Botox injection or so, still the pelvic floor exercise and the hormonal treatment will play a key role here. Without asking about the menstrual history, about hormonal, about the menopause, we will not be able to do any of replacement or not. Thank you.
Thank you very much. And we'll move to question 5. If my PSA is high, what happens next? Do I need a biopsy straight away?
Well, that was my presentation, is that we are moving from the old-fashioned direct to the biopsy. We are moving to a modern pathway of diagnosis of prostate cancer or prostate disease, if we can say. So that's mean not always cancer, because PSA can be up from so many other reasons. It can be raised from benign prostate enlargement. It can be up from infection. It can be up from inflammation, and or recent activity, like you have cycling, or you have recent ejaculation, examination, telescope examination, like cystoscope, when you come to a urologist. But all what I can say, it's simply a signal that further assessment you need. Thank you.
Okay, and I think question 6 was similar. What does a raised PSA actually mean? Does it actually mean?
You are right. You are absolutely right. Yes, it's the same. So it's the size of prostate. Of course, any one of us will be worried about cancer. That's the main worry, although it's 24% of those having high PSA will have cancer, but still it's too much. While almost all the rest will be between the benign prostatic enlargement, which is a natural phenomenon in any man after age of 50, and the infection and inflammation or recent activity. Yes, you are right.
Okay, thanks for that. Should I be getting my PSA checked even if I have no symptoms?
Well, I operate on patients age 37, 38, 42, 45, and so on. I think, and I believe, and every literature I read about the prostate cancer, all they recommend age of 50, you should have your PSA checked at least once annually. And if you have family history, you should have your PSA checked at age of 45, then 47, 49, and then after 50 annually.
Okay.
So age of 50, if you have no family history, age of 45, if you have family history. Of course, if you have symptoms, that's different.
That's extremely helpful advice. Thank you, Mr. Al Shammary. So the final question I have is question 8. Is there a danger of a prostate biopsy damaging the urethra? Is the biopsy done by the urologist or the radiologist? Any preference of who does it?
Well, this is a very good question. The damage to urethra is 1 in 100 cases. They may have sorry, my phone is just rang. 1 in 100 to have urethral injury, where you have bleeding in the urination for next 2 or 3 days, which is normal, and you don't need to do anything about that. It's very, very rare, very, very rare that you have catheter for urethral injury. It's done by urologists. It's a transperineal. The old form, yes, there was higher risk of injury. That's why we are not. I don't think we in UPMC they stopped the old method and they moved to the new modern transperineal biopsy, which is through the skin between the scrotum and the back passage. Between in that skin area, the needle will go direct to the prostate, guided by ultrasound, which is done by urologists while you are asleep or under local anesthetic. And the injury to urethra will be very rare because we can see when we do that. The UPMC introduced this in 2017, and I don't think, as I spoke to my senior colleague, Mr. Barry Jones, the last case was done in 2017 with the old method, which was done transrectally, which carries a higher risk of infection, sepsis, intensive care, admission, and the urethral injury. Yes, this is the transperineal biopsy through the skin, done by urologists, and carry a very slim chance to get urethral injury.
Okay, thank you very much. I have to say, Mr. Al Shammary, those questions and your guidance was very, very informative. I don't believe I have any further questions for you. Do you have any final comments or guidance to our participants at the event tonight? Thank you.
Thank you very, very much for this opportunity. We always here to help. We're at UPMC Kilkenny. Thank you very much.
Thank you. So a final thank you for all our participants for joining our event tonight. I hope you found it of benefit and it was informative. And I wish you all a good evening. Thank you very much.